All righty. Well, we'd like to welcome everyone to our webinar this morning. As part of our learning community for the impact of opiates on youth and families, we are sponsoring here at Center for Innovative Practices a set of webinars to give out some information. As a part of the webinars, we will post these I believe on our Wraparound Ohio website, which will give you more information about. And we'll have some materials as well that you can access, as well as the PowerPoint. I will let our presenters introduce themselves, but today's webinar is on the opiate crisis and the impact on families and children. And we're very, very privileged to have with us what we believe to be two of our state's experts on this issue, Tim Schaffner and Angela Lariviere, and I will let Angela do further introductions.
Thank you, Rick. As Rick said, I'm Angela Lariviere, and I'm part of this webinar today, along with Tim Schaffner. I'm currently the director of Youth Move Ohio and the founder of the Ohio Youth Empowerment Program. For the past 20 years, I have worked with multi-systems youth in Ohio to address issues affecting them on a policy, personal, and program level. I also have a lifetime of lived experience as a child, young adult, and parent of multi-system youth. With me today, advisor and partner in this presentation, Timothy Schaffner. Tim has served as the Executive Director of Trumbull County Children's Services for 12 years. He brings 37 years of experience to the table and has been a leader in the field of behavioral health and residential care of children. Before joining Children's Services, he also served as the Director of the Educational Valley Services in Warren, Ohio, and as the Director of Youth Services at Todd Hospital in Youngstown. So today we're going to be sharing our insights about the impact of the opiate crisis on children and families in Ohio. Need the next slide, please. So as you're aware, the opiate crisis in Ohio is affecting our families and our children, and some insight and also some facts and some resources that might help you in your work with these children and families. Next slide, please. Just a brief overview of some of the facts, and we're going to also discuss some other facts, is that Ohio is the second worst state in the nation for drug overdoses, with Dayton being ranked as the #1 per capita. We ranked #6 for the most deaths, and as a result of that, you can see what it would have an effect on children in those families. We know that in the last 3 years, that relative placement has increased 62%, and foster care placements have increased 11% across the state. And at the same time, while opiate use has increased, the state allotment for child welfare funding has decreased by 21%. And we think that's significant because it impedes our ability to actually serve the children, and that's some of the things that we're going to discuss today. Next slide, please.
So, Tim here. One of the things, of course, we want to be trauma-informed and view the issue at hand with trauma lenses. Thank you, Oprah, for having Dr. Bruce Perry on 60 Minutes and really getting the word out a few weeks ago to the general public on research that dates back to the 90s. So we're going to talk about that research a little bit and talk about this impact on the family, again, with our trauma lenses on. Next slide, please. Just a brief overview of our trauma perspective in general. We know why trauma is important. We've spent years asking what's wrong with the child, what's wrong with the family, and in our interventions when we ask what happened to the child or what happened to the family. We know that trauma can be acute, but more often if we're in education or child welfare or behavioral health, We know that trauma is pervasive, and to find a family with no trauma is extremely rare. We do trauma screening tools on every child we take into custody at Trumbull County Children's Services, and we know that our kids have an average of 4.8 adverse childhood experiences in their lives. Next slide, please. I think it's really interesting when we look at comparing kids in our child welfare system, or kids who have experienced abuse, neglect, or dependency, with a control population who haven't. This begins to bring it home a little bit, a 50% increase in language and speech problems. Who makes that connection? Real important for educators to know. A 9-time increase in developmental disabilities. A little bit more proof that the impact of trauma is organic, pervasive, and epigenetic. Increase in hearing problems, learning disabilities, and the last point, a 4-fold increase in attention deficit disorder. I often have to add that I think ADHD is a presumptive diagnosis, and it pops up in the research a little more frequently than often, because once we get to know the child and do a good trauma screening, we see that it's less ADHD and more PTSD. Next slide. Quick review of Kaiser Permanente and Dr. Vincifliti's research, looking at 18,000 subjects back in the 90s, and using an 87-question questionnaire. He identified the abuses and the life experiences listed on this slide. We know that the negative health outcomes can be incredible for this population. If you look into the adult health outcomes of folks who have had 4 or more adverse childhood experiences, the impairment of memory, heart disease, diabetes, those are through the roof. We know that the way that a person thinks is affected by this adverse childhood experience. Angela has an example of a case study that applies this.
So over these years of my life experience and my professional experience, I work with youth with multi-systems. For this PowerPoint, we're going to do 4 case studies, just looking at what that looks like from a youth point of view. So I interviewed youth who have had multiple points on the ACE scale, or on trauma impact. So if you could do the next slide. So this first one is Matt. And just a brief overview about Matt, has some massive, has multiple, at least 8 indicators for childhood trauma. His family had generational poverty, very little support. If you just look at the breakdown of his situation, abusive father, probably largely due to the opiate, addicted to opiates. Children were taken from house to house, living in drug houses, and then was isolated from the mother and family for 3 years. Another significant thing about that is once a stepmother came into play who was also opiate addicted, witnessed his stepmother's operation of smuggling opiates into the prison system. And at 14 could tell you exactly about 5 ways to sneak drugs in. So I think that's a whole different level. The ironic thing is that in most or all of the cases that we have today, that there has been child service involvement, but never a relinquishment of custody or no intervention for out-of-home placement. I think that my personal opinion on that, with my life experience and working with these youth, is that the system is just overcapacitated with these cases, and they just have no way to deal with the caseload. And sometimes, like some of these cases where you would think, obviously the children should be removed, there just isn't any way to do that. The impact on this, which I found matches what Tim was just pointing out, is diagnosis of ADHD, speech issues, having to steal for basic needs like food from a very young age, not trusting adults. One thing about a couple of these kids that we're working with is that some of them have been able to maintain a social network with their peers, but all of them have been fiercely defensive of their parents. And I'm going to point that out again, but violent towards their siblings. Indicator of, but it's a consistent issue. So next slide, please.
So that, Matt, is a wonderful example of the impact behaviorally, emotionally, how it affects all the domains of a child's life. We began to look at this seriously between 2013 and 2015 in Trumbull County. Our children in custody went up 40%, and the vast majority of those children were coming from homes where one or both parents were addicted to opiates. We got very good at connecting kids with kinship care 24/7 when we did join the police often in intervening in a home situation. So our numbers have gone back down. But what you'll see in some of the statistics coming up are that kids are staying in care longer, and these kids are in higher levels of care. And we really began to look at that and think about how are these kids different than this other group of kids who come in for abuse, neglect, or dependency, and those often related to alcohol or other substance use. Because this group of kids coming from opiate home seem to be quite a bit different. We know that it takes, the recovery process may be more involved. There may be more relapses when there's an opiate addiction involved, but we felt there was something more. So we looked at the literature and we looked at the reality, and we began to meet with intensive outpatient groups at our local recovery provider. Next slide, please. And if we look at and compare the life of an opiate addict, which remember is often sudden onset, it takes a long time to get up to drinking 30 beers a day or 2 bottles of vodka. We all know how rapid the onset of an opiate addiction can occur. If you look at what's going on in the opiate addict's life, and this comes right from folks who are recovering from opiate addiction, there are 4 things going on. They're drug sick. When they're drug sick, they've got to go find the money to buy drugs, and that's certainly a high-risk endeavor, oftentimes with illegal and with some nefarious people. Same with the drug seeking, the next activity that's involved, so got to go score, and finally there's an impairment. When we think about that life, and that generally every waking moment is involved in one of those states, we see a much different parent. We see a parent who is consistently lacking in attunement, attention with their child. Next slide, please. So we put that together, so the extended drug-seeking absences and and we see the impact on the child. So there are basic need consequences for these kids, and we begin to ask ourselves, when did this occur? So again, with alcoholism, there are periods of sobriety, the use, a much longer period of time, addiction. So really, at what developmental stage did this happen? This lack of basic needs, lack of attunement, lack of attachment, increased anxiety, and emotional emotional distance from the child. Next slide. We looked at the literature. There's not a huge body of literature, certainly not in this country, but it's out there, and I think we'll have a bibliography attached to the website. There is some substantial literature on alcoholism and the impact on parenting, but there's work out there on the impact of opiates. Next slide, please. So what do we see? So with substance use in general, the elevated risk of neglect, certainly alcohol being a legal substance to use, their exposure to other people using and to other impaired adults. But when we add on the increase chasing of the finances, chasing of the drug, and the drug culture, we do expose our kids to a lot more, frequently a lot more dangerous results. The last bullet, that drug use alone might not be the best predictor of parent quality, is of course a nod to not only what's wrong with the person, what is their addiction, but also what happened to them. So next slide. What we've got to look more at with, I know in child welfare we don't, and many of the behavioral health providers I know, part of the diagnostic assessment, but do we share a common language, and do we share common data collection on attachment? And we've provided, for the sake of this discussion, just some definitions of attachment. Think about when this occurred in a child's development using these definitions. What was occurring? What was the exposure to danger of the child? What was the exposure to abuse? And we can see a continuum from ambivalent attachment, where attachment is still important, to the avoidant attachment with for a child with challenge skills in socializing and making connections with others, and the disorganized attachment, which involves a fear of relationships with others because it hasn't worked out very well. If we look at the next slide and the impact of neonatal abstinence syndrome, our children's hospitals are responding wonderfully to this group of kids. And so in our major metro areas where we have the big children's hospitals, we're doing a great job, but there's still significant stigma and blame for the moms, increasing the challenges of caring for a child with these particular challenges. We have a lot of correlations with later behavior problems. Again, the attachment early in development is affected. If we look at some of the early, I think it was called still face research, where the researchers looked at the interaction of a mom and a baby normally, and then made the mom, or had the mom have a completely blank face. There was almost an immediate agitated and distressed response from the child. So I love that research, because think about it in application to a mom or a dad, a significant caretaker that suddenly checks out because of substance abuse. If we look at the next slide, we're going to have several slides in terms of what might be the impact, different developmental stages. If we do have a mom in recovery during infancy, those of us who have parented children before, and I've done it 4 times, know the stresses of early infancy. So besides the complication on the child's sleep and eating patterns and toileting patterns, there's guilt and worry involved, etc. So it increases our responsibility for these parents in early infancy to really pay attention to their recovery and supports, and to become aware, if that's the onset of the time of addiction, what the very real impact is on the infant and their development of dyadic interaction patterns, etc. If we move to the next slide and look at early childhood exposure syndromes, or symptoms, we begin to see not only the social impact, but the cognitive impact. It makes sense why we're seeing more hyperactivity and impulsivity with these children, with the oftentimes, again, sudden change in the parental attunement and attention as they develop. We also often, and it comes to the attention of child welfare, that we're beginning to see kids failure to thrive, not making their early well child appointments with their pediatricians, the impairment of their parents. Next slide on latency age kids, our 5 to 8 year olds. And now we've got a more mobile child. We've got a child who can leave the home. Parent is impaired. We probably get three calls a month in our county alone on kids who are wandering a quarter, half a mile, sometimes a mile away from home with no supervision. Sometimes it's that tired parent who worked all night and fell asleep when they were supposed to be watching the kid. More often than not, it's a parent on the nod due to substance abuse. So that, again, we can see a much different equation. The school age exposure symptoms, the next slide, we to pick up more of the developmental impact because we've got teachers aware of what's going on with children. Childhood depression, we begin to see lack of attentiveness in the classroom, symptoms of ADHD, and again, is that exposure to stress and trauma, or is it really an organic ADHD? And memory and perception problems. What happened at home last night? I don't know. Not an uncommon response. My last slide in this section, adolescence. In my own parenting, I call that the second terrible twos. Again, we've got a great opportunity with these kids in terms of their neuroplasticity and their ability to grow and change and respond to treatment in response to trauma. We've also got a really mobile child and a child who's kind of the world is their oyster, and without supervision, without attention and attunement, the consequences become much more serious. Angela's got another case study for us to emphasize some of these points.
So this is a case of Emily, and just going back to a couple of points that Tim just pointed out, and thinking about the case of Matt and some of the other youth that I interviewed, is they do have that attachment problem, particularly to adults. So one thing that we didn't put a slide on, but I do want to highlight, is that this becomes the importance of their peers and how we look at the support that we give, particularly to the transition age youth or the older youth, because they do have a mistrust of adults. They do interact differently with peers. So next slide, please. So Emily, in this case, has many, again, probably 7 or 8 ACE indicators for trauma. The significant thing that's different about her case is that she lived in public housing growing up with her grandmother and her mother. There were no male role models involved on any length of time, but both the mother and the grandmother were addicted and self-medicated, having some mental health issues and also depression, untreated depression and mental health issues. Emily was bullied a lot in school, mainly because of her poverty, and once she hit middle school, was having a real anxiety and depression about attending school. So the mother and the grandmother began to give her opiates to deal with school. And how they would get her to go to school was promise to give them to her when she got home from school at the end of the day. So she actually had been addicted. She's 25 currently, been addicted at least for the last 14 years. So that impact on her, as you can imagine, all those slides that Tim just went through at every phase of life, you can really see how that's affected her on multiple levels. The thing about her life right now is the fact that she understands her addiction. She doesn't like being an addict, but she has absolutely no path out of it. She has had 3 children so far that have all been taken into custody. She has no plan. I mean, she has a plan. She wants them back, but she has no capability of navigating. Housed as an adult. She's been in multiple abusive relationships. Both her mother and grandmother have passed away since she's become an adult. And she has no family support system. She also didn't complete her education. So as you can see, one of the reasons this is maybe seem like an extreme case to you, but my fear in working with youth and coming from these families is that we're going to see more of these situations like Emily, and we're going to have to figure out how to bring appropriate treatment to the youth and the children in the families, and we're going to have to kind of look below that tip of the iceberg that we're seeing right now and really build that into the case plan, because how this has affected her and now her 4 children as she's currently pregnant is just going to go on for a long time. There's not a quick answer to how we solve this crisis. Next slide, please. So now we're going to talk a little bit about some of the impact on child welfare. Just hearing those 2 case studies and knowing the work that you're probably all doing in the field, that there is a big impact on the child welfare system. Next slide, please. So here's a breakdown of facts according to Public Children's Services Association of Ohio, which Tim is on their board of directors, and I work closely with in partnership on a lot of projects. We have these discussions all day. As I said earlier, a lot of kids that are out there are not being taken into custody from my personal perspective, but statistically, we can see that 50% of children taken into custody have parents actively using drugs, and 28% of those confirmed as using opiates or heroin. 70% of children under the age of 1 had a parent actively using. If you match that statistic with that slide that Tim just went over on infancy, impact that's going to have on those children. And a slide that's personal to me is children living in relative placement has increased 62%. Those are cases where the child welfare system is involved. In my personal case, I have taken custody of relatives where there's been no child welfare involvement. It's just been a personal involvement. And I also know a lot of people in the neighborhoods where I work and where I live and where I work with other youth, that there are a lot of aunts and uncles and grandparents that are just intervening on a personal level and just trying to do the best they can for the children. So the fact that we have a definite number of a 62, I imagine that in the neighborhoods, that's a lot more. We also have the cost of increase due to those trauma-related issues that we're talking about, directly related to cases where drugs are involved. And I think I put that statistic in there twice. So we can go to the next slide. So this, what I was talking about before, is the fear of this crisis are the things that we don't see, are those youth and those families, those children that are in families that are just outside of the system and aren't really being counted officially in statistics. Next slide. So the stress on the system. So I don't see this, and I don't think the youth that I work with see this as a failure of the system. We see that the opiate crisis has just fallen by default, mainly on the child welfare system. and some of these statistics support that as well, is the cost of residential and out-of-home care has increased, and the funding has decreased. And the statistic that was most terrifying to me is the fact that Ohio ranks 50th in state child welfare funding. So that means we are behind every other state in how much we're actually putting into this crisis, while we are the second highest state with the opiate crisis. So that means that all of that increased in those trauma services that these children and youth are needing, we really don't have a fiscal path to solving that issue. And that's also impacting the shortage of frontline staff, because 1 in 4 caseworkers left their positions for multiple reasons in 2016, but moving on to other positions, but 1 in 7 left the system altogether. And I was just in a meeting with some child welfare directors in a couple of counties that said that they have so many available positions, and they're trying to recruit social workers and case managers from anywhere at this point, just to meet their current need. So I think we really need to do a better job in looking at that issue, and I'm not suggesting how to solve it, but I think it needs to be one of our main focuses. Next slide, please. So this one is Lauren. This case study is Lauren. She's 20 years old. So next slide, please. So the thing about Lauren, when we put this one in, is Lauren kind of used her situation as motivation of trying to pull away from the life of her mother and father, and she watched them struggle with addiction. Their whole life has been about mobility, living doubled up with relatives and out of care. I think what makes her situation a little more stable is the fact that they have, while in poverty, they have an extended family that has been supportive of each other. Whether that's in a functional way or dysfunctional way, they always seem to try to pitch in to do what's necessary to help each other in crisis. But recently, her mother has become really far into her addiction. Her father was incarcerated, and she has young siblings, elementary school age, that have been placed into care. And how that's affected her is the fact that once they were taken into care, she was 19, so she was too old for any services. So they're getting services, but she is not. And it kind of took away her motivation, because her motivation has been as the primary caregiver of her siblings. Now she's moved into becoming depressed, and she's been diagnosed with bipolar recently and PTSD. And I think some of that has to do with losing her place as the primary caretaker. Her mother is now not doing better, doing worse, and the siblings, it looks like, will be in permanent custody. One of the good things about that is children's services, or the child welfare changes, has allowed her to be able to have contact and visitation. So she does get visitation with them, which is really keeping her on task, along with her trying to obtain goals like trying to attend college. Next slide.
So what do we do? So we've got kind of a different challenge to the children that we all have to take care of, a different kind of family challenge, and let's look at some practical ways to assess that and to intervene with it. Next slide. So we want to, just in our everyday interactions with the children, we're going to get to that comprehensive assessment done by a behavioral health specialist, but we want to look at what that interaction is between the child and the parent. We recently had a family, an infant with multiple fractures, a 3-year-old and a 5-year-old, and one of the things we found very interesting was the kid's relationship with the father and the kid's relationship with the mother. and the interaction. It became obvious that the father's the primary caretaker, the mother much more distant from her children. Interestingly enough, it's the father who admitted to the abuse of the infant in the home. So I want to look at all those dyadic interactions, the eye contact, the level of play, etc. Next slide. We would suggest formal assessment tools for the folks that are doing, if you're in child welfare, that are doing assessments for you. If you're a behavioral health provider, that maybe look at the use of some of these tools to inform the multi-system team working with the child in the community. And those are some example of different tools that you can use. We've begun to use some of these tools. We have an assessment department with a PhD psychologist at Trumbull County Children's Services. Next slide, please. One of the things that we think about in our parenting classes is, are we providing them the tools that they really need when we create a case plan and we send them to a parenting classes? What do typical parenting classes involve? How to structure your day, how to set rules for your kids, how to develop consequences, how to avoid corporal punishment with your kids, how to communicate with other caregivers of your kids, how to communicate with the school. Really good practical stuff, but it's possible that maybe we need to get a lot more basic than that. And with parents, focus on attunement, focus on attention, focus on relationship development, focus on what kids need from their primary caregivers in terms of that level of their development. And we suggest on this slide some different interventions in groups that are, if not evidence-based practices, promising practices. Next slide. What can we all do, whether we're in a classroom, whether we're law enforcement responding to a situation, whether we're child welfare, whether behavioral health specialists? We talk about the stages of treatment of trauma, and these apply with any kids with trauma, and particularly with kids who might be experiencing attachment problems. Stabilization and trust and safety. When I work with groups of providers or caseworkers, I talk about what do you do when you first meet somebody to help them feel safe. Really important stuff to look at. How do you provide stabilization? What are the rules? What's going to happen? The number one complaint about healthcare from consumers of healthcare is we have to wait and we don't know what's going to happen next. So in any interaction with another person, that's the first thing. What am I doing here? What's going to happen next? How long it's going to take? What behaviors build trust? And most importantly, what can I do to help you feel safe? And what makes you feel not safe around other folks? What else do we want to look at? Certainly the trauma work. When Dr. Bruce Perry came to Neomed to provide an all-day in-service for surrounding counties in 2013, one of the first things he did was ask for a show of hands. How many clinicians in the room have been trained in trauma-informed CBT, cognitive behavioral therapy? And he probably got about 200 hands that went up, and he said, that's great. Good job really being trauma aware, but that's probably not going to work for most of the kids that you're working with. And what he talked about was interventions like EMDR and adventure therapy and interventions that are going to provide that trust and safety and relationship and attention and attunement, but real sensitivity that these kids are not in their cortex. They're not in the thinking part of their brain frequently, at least early in the intervention. And then stage 3, learning to live in the moment. I always say when you figure out how to do that, please call me and let me know how I can learn to do that. But we are doing more things in our schools. Tim Ryan, our congressman, got us a grant in the Warren City Schools where we're doing a lot of mindfulness activities with kids, a lot of regulating activities, and we can see the outcomes in terms of kids' behavior in school. Westerville, north of Columbus in Ohio, we're seeing a lot of results in their elementary schools with a lot of the regulating activities that those teachers are figuring out on their own. Next slide. What can we do as a system? Certainly drug courts, our family dependency treatment court in our special dockets court in Trumbull County has wonderful outcomes with moms and dads and their kids. They're getting their kids back sooner, and we're experiencing less relapses with these folks. We wrap a team around a mom or a dad, and frequently a mom here. And we have recovery coaches in the room every Friday morning at 10 o'clock. Everybody's at the table doing a case review on every case in our court. High fidelity wraparound. I can't say enough about that. We're blessed in Trumbull County to have used the Vandenberg model since 1992. We live, breathe, and drink that Kool-Aid every day, and we can see it in our outcomes. We keep kids at home with their families that many other communities can't. Angela's going to talk about some more action steps.
Let's unmute. So we've talked a lot about some negatives and where we are, because I think we really do have to be honest about where we are, even if it's scary. But we also need to focus on some of the resiliency and how we build resiliency in the families and the youth and the children that we work with. Next slide, please. So here's our last viewpoint case, relative placement with Mary, who's 8. There's a picture in the beginning. There's a more recent picture next to her. Next slide, please. So Mary is the 6th child of parents who start out as teenage parents. They have some family, but not a lot. Both parents were addicted. I think a key factor in Mary's resiliency, not addicted to opiates before she was born, but got on them right after her birth. But the father had been addicted long-term before she was born. She also was taken all over, moved a lot while she was an infant, in drug houses, transitional, and also while she was an infant in her first 3 months, was often left alone and unfed for hours. There was children's services, mild children's services involvement, but no out-of-home placements, and lived unofficially in relative placement. So we'll say that I saved this case for last for a couple reasons. This happens to be my niece, and she happened to be in relative placement in my house a couple of times when she was an early child, and then just briefly for about 6 months when she was 3 years old. In between, her parents had first and had a lot of drama and trauma. My sister has gotten clean off of opiates, but struggles massively with mental health and depression. But a key factor, as Tim and I were discussing this while we were working on this presentation, my daughter happens to be a case manager MSW. And from the beginning of Kaylee's life, we have wondered one thing. She is happy all the time. And I just got her yesterday to confirm that. And I asked her, are you happy all the time, some of the time? She said all of the time. So the impact on her hasn't really seemed to be negative at this point at 8 years old. She has great grades. She's happy, as she said, all of the time. My sister did put her briefly in counseling during splitting up with her father, but the counseling service said she didn't need it. All of her other siblings have really the opposite outcomes. She has very limited interaction with her father, and she's in great physical health. Why I wanted to talk about this is we have talked about literally for hours in our family, and there are two factors. My husband and I got them stable housing once Kaylee was about 6 months old. She's been in the same house, in the same neighborhood, in the same elementary school with the same teachers, and also with my adult children and my husband and I. So I think a lot of those factors with supports, she has been protected from. And that was some of the things that Tim had pointed out back in the different stages. Some of the impact, the trust factors, the abandonment, and all of that seemed to be that underlying stability factor, which was one of the things on the previous slide. And what we need to do moving forward, I think, is to look at not just Mary's case, which all of the names have been changed in this presentation, but not just in her case, but also in those other cases, in Matt and Emily and Lauren, is to look at these youth, even in Emily's case that's extreme and she's been addicted for so long. If we really work with them, even in that extreme case or even in Mary's case, and we can start to pull out those factors, not just looking for the trauma factors, but the resiliency factors, then I think we can do a better job of how we support other children coming out of these situations. In Emily's case, being addicted her whole life, the thing I found so fascinating about that is that she is hopeful to one day not be addicted to opiates. And the fact that she's 25 and still hopeful after all of these years of struggle, we need to figure out how to really harness that and apply it to other cases. So next slide, please. I'm going to give this one to Tim.
Oh, yeah, so what do we do? So as Angela's saying, is what we say all the time, treatment works, people recover. We know that with adults who are recovering from addiction. We know that with kids and adults who are being treated for trauma. We know what works beyond the therapy. We have an old saying in our work with chronically and persistently mentally ill adults, we can't just feed them medicine and therapy. We need to take care of a place to live, a job to go to, and a date on Saturday night. So meeting those basic needs, those basic social needs, and that basic value of how I spend my day. The slide you're looking at, what can we do? We know we're happy in Trumbull County. Dr. Scheffler and Dr. Beal from Centers for Innovative Practice came from Stark County, and they've been at this probably longer than anybody else in Ohio responding to trauma, and have groups that meet regularly and look at what we're providing, looking at providing training to the professionals and teachers, and keeping trauma and resiliency top of mind. And Franklin County received a large SAMHSA grant several years ago, and have launched a very effective training and intervention program in their community led by Franklin County Children's Services. A single trauma screening tool, a single tool between agencies is a huge lift. It took us 4 years, but in Trumbull County, we've got a survey monkey that no matter how we collect the data, we can enter it in the survey monkey because we want to know how pervasive is trauma in our community. If we're looking for grants, if we're looking for gaps in services, we kind of need to know that. And so we're here to tell you it's possible to adopt a single tool. Certainly our strengths-based approaches are important. The number 5, positive, stable relationships. One of the things Dr. Perry talks about, one of the things we know in child welfare from our work is mentoring. Franklin County has a healthy mentoring program. We have an early program in Trumbull County, but a single, responsible, attentive adult meeting with a child 1 hour a week throughout their childhood makes a huge difference in outcomes for kids. We know that. And you know what? Those aren't really hard adults to find. Coordinating services between all agencies, we'll tell you high fidelity wraparound all day. It works for us. The engaged program, and thank you, Case and Centers for Innovative Practice, for helping us launch that across the state. It really, really works, and we hope that everybody continues to focus on that. And lastly, we need to pay attention to secondary trauma. If you want more on that, look at the Sanctuary Movement. Google the Sanctuary Movement, the work that they're doing. We do every 2 years, all of the agencies that deal with kids, we do a self-assessment as to how trauma aware our systems are. And it's really helpful to measure our progress. And we are growing little by little. Angela, what do the youth say?
So I just have a couple of things. The next slide, please. So a couple of dozen youth that I've worked with recently, I kind of collected all their thoughts around what they wanted to give to you on this advice. And basically they have the message of these points. Don't forget about them, hear them, value their knowledge and experience. They have a lot of insight to their situation. If you can build that trust, they can give you insights even in the treatment of their parents that you might not get otherwise. Remember to walk in their shoes. So if it takes them a while to build that trust, know why. And don't blame them for adult actions. They feel like they face the most punishment and consequences of adult actions. And I hear this over and over and over again. It's easier to control a child and to blame them for their behavior, to punish them for their behavior, to put them on medicine than it is to get an adult to comply. And they recognize that. They see, why are we being punished? Because adults didn't do what they were supposed to do. Remember that they need specialized interventions and services as much as their addicted parents, and they need to be included in their treatment plans and updated on their parents. Because a lot of times, if they're taken, particularly if they're taken out of the home, they are being protected from what's going on with their parents, but really just causes them to worry about what's happening with their parents, to the point of a lot of them becoming obsessed and depressed by not knowing what's happening to their parents, and that they always love their parents and will always defend them, even if it seems ridiculous to do so, and if there can be some respect about that. Next slide, please. Recovery is possible with support. We definitely need all these systems. So if you work in any of these systems, to start coming together and having that conversation. We know that each system could bring different resources and insight and perspective on what's happening with these children. And if we do work together, we will be able to have a more positive impact on what's happening. I think we have about 5 minutes left, and I'm going to share a couple of my last thoughts, and then I'll let Tim wrap us up. But just to recap, like there is a need to match funding with the crisis on all levels, not just the immediate law enforcement level, prison system level, court level, but on that intervention and treatment all the way down to the infant that's affected by this crisis. We need to look at how we're supporting our frontline workers and how we're supporting the child welfare agencies so that they can be more effective, and we need to trust them on their expertise about how that works. I see a real need to link that child welfare perspective with the school perspective, because I think there are a lot of gaps in how these youth are being treated in education. My fear around that is that they will give up on education and quit school because they're just not being supported in an education environment. And again, I think that's a system, that's a stress on a system, because teachers can't fix everything when they have 20 or 30 kids in a classroom, and we need to figure out how to work together on that level. And then we can't move fast enough. This is not a crisis that we can afford to have a 5-year study and then figure out what to do. we need to be moving now. And Tim mentioned this, and I like, we do need evidence-based practices, but there just aren't enough out there right now for this particular issue. And I like how Tim put it as promising practice, and we need to trust in promising practice. And I think one of those promising practices is how do we incorporate those youth who have become successful or resilient despite this crisis to be involved in the conversation on how to help other youth, not forgetting the value of peer support. So with that, I'll leave the last couple of minutes to Tim. So turn that back over to you.
Okay,
and we can
thanks, Dan.
go to the next slide of resources as well.
Cool resources on your slide. Just a couple final comments. The stigma doesn't help. So it's all about all of us sharing in the battle to fight the stigma. That addiction is a disease. Sure, there's choice in the beginning. The disease takes over. Addiction is the only disease. It's the only life-threatening illness in most communities where you can't get life-saving treatment immediately. And I can't say that enough. When an addict or an alcoholic is ready for treatment, you often can't get it for 2 days or 7 days or 10 days in a community. Help us expand on the research that we're talking about today. Use some of these tools. Give us feedback. Our email addresses are up there. The folks at CASE, at Centers for Innovative Practice, are always there to help us flesh out and implement the kind of things that we're talking about. So we would love your feedback. We'd love to learn with you. And finally, the answer is in the first word of the 12 steps of Alcoholics Anonymous. I'm not going to tell you what it is. I'm going to say look it up. Thanks for the opportunity to talk about this important message.